I want to see if we can move along and get through as much of the respiratory system as we can. The first part that we're going to look at right now, I think, is probably the most sort of semi-complicated in terms of the anatomy. Before we get into it, I want to, again, reiterate this idea of the anatomical distinction of the two parts of the respiratory system versus the functional distinction, right? The anatomical is upper and lower respiratory tract, right? And where's the boundary between the upper and lower? At the larynx, all right? Or you could say at the bottom of the pharynx, right? Right? At the bottom of the pharynx, at the bottom of the laryngopharynx, all right? Okay. Above that is the upper respiratory tract. Below that is the lower respiratory tract, all right? That's in an anatomical subdivision, subdividing it anatomically. If we want to subdivide it functionally, we have two parts, the conducting portion and the respiratory portion. And the conducting portion takes us from where? From your nostrils into the vestibule, into the nasal cavity, through the choanae, into the nasopharynx, oropharynx, laryngopharynx, through the rima glottis, all right, that is through the larynx, the opening in the larynx, past the vocal cords, all right, into the trachea, through the primary bronchi, the secondary bronchi, the tertiary bronchi, and the 8 or 10 more subdivisions that follow, down into the bronchioli. All of those are conducting components, which we're going to talk about today. All right? And when you get to the very end of those passageways, the very end of these smooth muscle tubes that are less than 1 millimeter in diameter, you're going to get down to the respiratory bronchioli. That's the first time you start to actually exchange gases, which is to say that's the first time you've reached the respiratory portion. Everything above that was conducting. All right, and it's not till you literally get to the very bottom of this passageway, to the very dead end, that you get to the part where gases are exchanged. All right, and we're going to look at that tonight. So let's get into what I referred to last time as tiger country, looking at the larynx, the voice box. All right, and when you look at the voice box, I want you to be thinking about 9 cartilages. All right. Some muscles, the hyoid bone itself, but the cartilages are the ones that we're going to focus on here, and that is 3 individual cartilages and 3 paired cartilages, all right? And 3 paired means 6 plus the 3 individual totals up to our 9, all right? And the 3 individual ones are the thyroid cartilage, which you see here, and the thyroid cartilage is, of course, the one that you feel when you feel your Adam's apple, all right? It is a 3-sided cartilage. It sits anterior and it sits laterally. All right, so it's forming 3 sides of a box. All right, just below that is the cricoid cartilage, and the cricoid cartilage is a complete ring. All right, so there's a big difference between these two. All right, whoops, and whereas the thyroid cartilage is broad in its anterior face, all right, the cricoid cartilage, which is a complete ring, is broad in its posterior face, all right. So here's the posterior side of the cricoid cartilage, all right. The third single cartilage is the epiglottic cartilage, all right. And the first 2, thyroid and cricoid, they're made of what kind of cartilage? Hyaline, all right. And the epiglottis, the epiglottic cartilage, is made up of elastic, all right? Okay. And show me how your epiglottis is positioned with your hand. You should all be waving at yourself, all right? Like that. It's like that, all right? So that it sits anterior, all right, and aiming backwards, all right? So that when you swallow, what's going to happen? When you swallow, you're going to raise the larynx to meet the epiglottis, all right, to meet that fibrocartilage cover, all right. When you swallow, it's not going to go down. There's no muscles that are going to flex that thing. It sits like this. When you swallow, the larynx goes up to meet it, all right, and puts the lid on the airway so that food goes down into the esophagus instead. Okay? All right. So those are the single cartilages, and we'll look at the paired cartilages a little bit. The arytenoids, the corniculate, the cuneiform. They're all paired. All right, they're little tiny cartilages, and we'll take a look at them here in this figure, which the labels don't show. Do they? Do you see the labels? No. Why is that? Maybe, do I need to click it a few times? Oh, yeah. There you go. Okay. All right. Okay. Good deal. All right. So let's take a look. Again, orient yourself. Here's the anterior view. There's your thyroid cartilage. There's a cricoid cartilage there. All right, looking posteriorly, here you see the epiglottis then. All right, again, this is looking from the back, right? And there you see it waving to you, all right, waving posteriorly. And again, orient yourself here. This is anterior, all right, as we look at a mid-sagittal view. This is anterior, this is posterior, and you can begin to see the paired cartilages here. The cuneiform, all right, the arytenoid cartilages, and the corniculate cartilages here. All right. So these are tiny little paired cartilages, and they're going to be involved in the ability to generate sound. All right. So they're connected to both the false vocal cords and the true vocal cords, and we'll take a look at them in just a moment. Okay. All right. So here you can see the true and false vocal cords. And these are really folds at the opening of the airway. All right. The upper one, known as the vestibular folds, all right, they're folds simply because there's ligamentous tissue that's running front to back. All right. And then it's covered with a stratified squamous non-keratinized epithelium. All right. Why? Because those vocal cords sometimes are in contact with one another, rubbing and vibrating against each other. So it makes sense to have a stratified squamous, non-keratinized epithelium there. All right. The upper ones, the vestibular folds, are really just there to protect the more inferior true vocal cords or vocal folds. All right. And the vestibular folds then are attached to the corniculate cartilages, and the true vocal folds are attached to the arytenoid cartilages, which are inferior. Okay, and you can see then the folds here. All right, as we go down into the airway. Okay, again, vestibular folds above, protecting the more inferior true vocal cords or vocal folds. Okay. All right, and again, these are ligaments that are running front to back. Right, we're going to look at them here. Right, the rima glotidis is just the opening. All right, so it's just the open space, and the glottis is actually the open space plus the folds that frame that space. All right, and as you can see here, we can by rotating the arytenoid cartilages, we can change the position and tension of the vocal folds. All right, and so we're going to see these vocal folds, all right, opening and closing, and as they open and close, you're exerting tension on them. All right, and the more tension, like a violin string, right? The more tension, the higher the pitch, right? Right? If you've ever plucked with a guitar or a cello or a violin, right? Those high notes are the thinner strings that are pulled really hard, tight, right? And at the low end, they're much, much less tight, and they give a lower pitch, all right? So when we think about speech can only be generated if you're blowing air up past the vocal folds, because what you're trying to do, as with a musical instrument, a string instrument, is you're trying to get them to vibrate, all right? It's the vibrations that are going to generate the sound, all right? And you're going to then draw tension on these, all right? And that tension is drawn by simply taking these the arytenoid cartilages and changing their position, all right? And by changing their position, they're pulling more or less tightly on the vocal folds, all right? The range, all right, meaning do you have a soprano's voice or do you have a tenor's voice or whatever, all right, is due to the length of those folds and their thickness, all right? So in males, especially, because the thyroid cartilage is stimulated by testosterone and becomes broader and essentially deeper, all right, that creates folds that are much longer, okay? And so you're going to have a lower voice. Edie? So you have little intrinsic muscles that are going to rotate the arytenoid cartilages, and as they rotate, they simply draw tension on the vocal folds. Okay, all right. So the pitch, all right, is going to be generated. The pitch meaning the frequency, all right, of the sound, high sounds or low sounds, all right, which is what your voice is, right? You're just modulating the frequency, right? Is going to be done by the intrinsic muscles shifting the position of the arytenoid cartilages, all right, so that you're pulling more tightly on these, and as you pull more tightly, you're increasing or decreasing the tension, all right, on the vocal folds, all right, and that in turn affects the pitch, all right. The loudness has to do with the amount of air that's passing by those by the vocal folds, all right. So you push more air, you get a louder sound. And then you have other components of the airway that are affecting the sound of your voice, as you know, when you have a cold and your sinuses are all clogged up, or you have a lot of mucus in your nose, or you simply plug your nose and try to speak. All right, in any of those instances, you start to see how these resonance chambers, all right, your sinuses, the nasal cavity itself, the shape of your mouth, all right, the position of your tongue, all of these things contribute to amplification and shaping the sounds, all right, and all the way, even to what's happening at your lips and your tongue and your cheeks. Okay. All right. So that gets us past the larynx. And take a little time. Your book does a real nice job. It's not super complicated, but take a little time just to review that in your books. All right, and sort of go through those bits. I'm not, extremely concerned about your knowing exactly how each different sound is generated, but just to have a general sense. You're changing the tension on the cords by rotating the arytenoid cartilages. By changing the tension, they're going to vibrate differently as air passes by. The more air, the louder it gets. All right, and get a little, take the time to review that. Okay. Once we get past the larynx, all right, and so here you see the larynx then, which extending, from all the way from the thyroid cartilage down to the cricoid cartilage. We get down now to the airway or the windpipe, all right? And you see it here, as you know it, the trachea, all right? And the trachea sits anterior to the esophagus. So here is a cross-sectional view, all right? Anterior is at the bottom of this image, posterior is at the top, all right? Here you see the esophagus, and you see that the esophagus is closed, all right? Whereas the airway is always patent, right? Patent is the term to describe that it is always open, right? You always want your airway open, right? Whereas the esophagus only needs to be flexed into an open position when there's food in it, okay? All right. And so, as we descend down through the trachea, you see here that its patency, its openness, all right, is maintained by these cartilaginous rings. And these are hyaline cartilage. Here you see, well, you'll see that figure in a moment. Here you see the hyaline cartilage. They're little C-shaped cartilages, 15 or 20 of these, all right? And in between them, you have the annular ligament, all right? And what does annular mean? It's a ring, all right? It's a ligament that goes in a ring that completely fills the space in between each of these cartilaginous rings, all right? And along the back, where the C-shaped cartilage, all right, is not, right? Here's the C-shaped cartilage, like a horseshoe, okay? Along this back part, you have a muscle, the trachealis muscle. And that trachealis muscle does two things. It creates a soft surface adjacent to the esophagus. So as you are swallowing and you have food in the esophagus, that part of the airway is able to yield to the food as it passes down posteriorly to the airway. All right, so you have this soft backing or soft surface that's opposing the esophagus. Secondly, that muscle, all right, the trachealis muscle, when it contracts, closes down the airway. All right, and if you're aspiring debris, if I'm working in my shop and I'm milling out some wood and there's sawdust in the air, all right, if you're walking by one of the grounds people here and he's got his blower going and there's a lot of particulates in the air, all right, you will constrict that muscle. It will close the diameter of the airway so that when you exhale, what happens to the velocity of airflow when you reduce the diameter of the airway? It's faster. All right, you increase the velocity. All right, you can think of it as taking the cardboard tube from a roll of paper towels. All right, and blow through that and see how fast the air moves out the other end of that. Versus take a little drinking straw and blow through that. All right, and exerting the same pressure, see how much faster the airflow is through the small straw. Right, and so that's what you're doing, and you're able to change then the diameter not only of the trachea, but of each of the other components as well. Okay? And this allows you to clear the airway, all right, of debris by simply constricting down those muscles, including the trachealis muscle here that we've just talked about. All right, the lining is, as you would expect, pseudostratified ciliated columnar epithelium with a bunch of goblet cells in there. And the goblet cells are part of the mucus production system here in the airway. It extends beyond simply the goblet cells. So goblet cells are found up here in the epithelium, in the pseudostratified ciliated columnar epithelium. There's a scattering of goblet cells in here. In addition, you have mucus-secreting glands in the lamina propria, and you've got mucus-secreting glands extending all the way down into the submucosa. All right? And here you can see these very clearly great big mucus-secreting glands. And of course, what you don't see, but you know is there, is a duct, right? Because these are exocrine glands, and they're connected by a duct from their place of residence here, where the gland itself is. There's going to be a duct that winds its way up and releases that mucus directly into the airway. All right? And there's a continuous then delivery of mucus into the airway, and likewise there's a continuous activity of cilia, right? Beating upwards, creating a sustained current of mucus flowing upwards, 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 upwards toward the rima glotidis, right? Where you can give a little exertion of air, there it is, and push it over the edge and swallow it, taking it down into your esophagus rather than allowing it to drain down into your lungs, right? And here in this nice picture, and why I included this, is that you can see down here your little cartilages, right? This is your tracheal cartilage, the little C-shaped cartilage, and it's quite obviously hyaline cartilage. It has that nice clear glassy look to it, no fibers in it, all right, that you can see, okay? All right. We extend then all the way down into the mediastinum, all right, and you get down to this ring here that subdivides the trachea into two passageways, the right primary bronchus and the left primary bronchus. And this is called the carina. The carina. It sits at the bifurcation. And as you can see, before I move on away from this figure, as you can see here, the right primary bronchus is pretty much straight, isn't it? It's almost a vertical continuation, almost, I say, not quite perfectly, of the trachea, isn't it? Whereas the left primary bronchus is definitely directed laterally, isn't it? All right? So where do you think, when you aspirate something, where do you think it usually goes? Yeah, it usually goes down into your right lung. All right? Or that's the most likely place to look for it because you see that direct line there. Okay. So let's take a look now at the bronchial tree then. All right? We begin at the carina, and we have the origins then of the primary bronchi. And you've got one primary bronchus on the right and one primary bronchus on the left, and you see them here color-coded in green. This is a neat figure, actually. It's really neat when they actually do this. Take a set of lungs, remove all the soft tissues, leave the bronchial tree, and it's just a magnificently beautiful system for in terms of the distribution of passageways to the leading down into the respiratory portion of the lungs. So where the primary bronchus enters into the lung tissue itself is called the hilum. All right, and that hilum, of course, sits on the medial surface of each lung. Correct? All right. The hilum sits on the medial surface of each lung, and it not only allows entry of the primary bronchi, but it also allows entry of blood vessels and lymphatic vessels and nerves, all right, going into the lungs. All right? The hilum, H-I-L-U-M, the hilum. All right? And in fact, that term hilum is a general anatomical term. It isn't limited to the lungs anytime. The kidneys, where you have the indentation on the medial surface of the kidney where the blood vessels enter and exit, that is also called the hilum. Okay? All right? It's the place where things enter and exit, okay, from these organs, okay? And just for a moment, thinking physiologically here, so we've got, of course, the airway going in. You know what that's doing there. That's bringing the air in. You've got blood vessels. That is the pulmonary artery bringing blood that is high or low in oxygen. Low in oxygen, all right? And then exiting the pulmonary vein, bringing blood that is high in oxygen. It's just been oxygenated, and it's going back to the heart now. All right? And the nerves, what's their function in all of this? What do you think your nerves are doing there in your lungs? No, these are nerves that are going to the lung tissues themselves, and we're going to see shortly that the inflation and deflation has nothing to do with the lung itself, but rather it's the musculature of the chest wall that's going to lead to inflation and deflation. So what are these nerves doing? Probably, maybe to some degree, but that would be pretty remote, all right, pretty minor. So what they're doing is there's motor component. It's going to be acting on the smooth muscle of the airway, what we just said a moment ago, to close down the airway, right, to bronchoconstrict or bronchodilate, right, or really to work at the bronchiolar level, all right, at the level of the smaller passageways, all right, again, to constrict or to open them up, right, to open them up because you're exercising and you need a lot of air. Let's open them up. Let's get some air going here. Close them down because there's a lot of particulates in the air and you want to allow for a rapid movement of air to clear the airway, right? So you have motor function controlling the smooth musculature, all right? You also have sensory there, all right? And that sensory sends signals to your brain telling you how much you have inflated your lungs, all right? Some of you in physiology learned something called sometimes it's called the respiratory reflex, or more formally it's called the Herring-Brewer reflex. Who's ever heard of that? Anybody? All right. So be that way. All right. So The Herring-Brewer reflex is simply a reflex that tells your brain how inflated your lungs are. And it basically contributes to the cessation of the impulse to inhale. In other words, as the lungs inflate, they're stretching. And as they stretch maximally, do you need to keep inhaling? No, maybe it's time to exhale. All right? So those nerves are picking up, they're stretch receptors. All right? And they're picking up the extent to which the lungs have been inflated. All right, so we have then our primary bronchi, all right, and then we go into our secondary bronchi, and you're going to see that there's 3 on the right and 2 on the left. Why is that? Well, I'll give you a hint. These are sometimes called lobar bronchi, as in they go to the lobes of the lung, and there are 3 lobes on the right side and only 2 on the left side. Why is that? Because your heart occupies part of the space on the left side, all right? And so the left lung only has 2 lobes, and therefore it only has 2 secondary bronchi, all right? And the right lobe has 3, or the right lung has 3 lobes, and therefore 3 secondary bronchi, okay? And those then subdivide again, all right, into tertiary bronchi. And those tertiary bronchi go into what are called the bronchopulmonary segments. All right, we're going to talk about those in a second. All right, but the point here is that you have another layer of branchings. All right, and these go into distinct, separate regions of the lung. And this is worth knowing about, because when you think about infection, all right, because each of those tertiary bronchi go into a discrete region of the lung, all right, called a bronchopulmonary segment, then very often you can pinpoint where infection is, all right, or where cancer is, all right, and you can go in, and because it's a discrete section, you can treat that section. At the very least, you can treat that lobe. All right. So in the case of cancer, you could just remove a single lobe instead of removing the entire lung. All right. Because the airway is literally subdividing at the same time that the lung itself is subdividing. All right. So you have that correlation. All right, between the airway and the subdivisions of the lung at the level of right and left lungs, at the level of the lobes of the lungs, 3 on the right, 2 on the left, at the level of the bronchopulmonary segments, of which there's more or less 10 on a side. Right.
I'm a little confused, because I know you said the right side is the one that is a little bit more vertical than the left side, and that's showing that there's 3 on the right and 2 on the left, and that's showing there to be on the 3 on the left. So I understand that, but the left side looks like it's more vertical.
So this is the right side.
Yeah, but then
it's more vertical.
The blue, there's only 2, and then on the other side there's 3.
Well, that's not so easy to see that. All right. Here's 1, 2, 3.
Okay.
All right.
Okay.
All right. It's not as easy to. That's okay. All right. Yeah. Get back to your anatomical position. Right. It's how the patient is. All right. Okay. All right. So another final word here on the bronchial system. All right. And that is that the bronchi, unlike the trachea, all right, where you have the tracheal cartilages, which are C-shaped cartilages, all right, in the bronchi there's still cartilage, all right, because you want to keep the airway open. But the cartilage is not a continuous ring of cartilage. Instead, it's plates of cartilage, all right, overlapping plates of cartilage. And that means that those overlapping plates, if we were to sort of illustrate those, all right, here's a bronchus, all right, and the plates of cartilage would be like this. Okay, you get the idea? So you can reduce the diameter or expand the diameter here, and they're able to slide past one another. All right, you're able to change the diameter versus the system that exists in the trachea, where it's not a full ring, and so you're able to change diameter in a slightly different way there. All right, but here these are plates, and so when we think about the structure of bronchi, there's cartilage, there's always cartilage, and there's always pseudostratified ciliated columnar epithelium, all right, lining that, unless you're a smoker. And in the case of a smoker, eventually that pseudostratified ciliated columnar epithelium gets replaced by a stratified squamous epithelium, a little tougher epithelium, but it doesn't do the movement, right? Okay, so you change sort of the nature of that. Okay, and as you get further down into the airways, we get down into the bronchioli. All right, that pseudostratified ciliated columnar epithelium turns into a ciliated columnar epithelium, so it becomes a little bit simpler in its appearance. All right, pseudostratified ciliated to simply ciliated columnar epithelium. All right. What is the soft tissue forming the airway? What is the soft tissue forming the airway? The hard tissue is these cartilage bits. What's the soft tissue? It is smooth muscle. It's smooth muscle, right? And that smooth muscle is going to allow us to change the diameter of the airway, all right? And what do you know about smooth muscle? It is involuntary, right? It's involuntary, and this is what I was saying earlier. The nerves are going to be acting on these smooth muscles, right? When we get past the tertiary bronchi, all right, there's 6 to 9 more levels of branching, okay, before we get to the bronchioles, all right? And the bronchioles are really tiny, all right, 1 millimeter in diameter, all right? So they're really small, and because of their small size, they don't require any cartilaginous support. And that is really the structural distinction between a bronchus, which can be very small, but as long as it has cartilage, it's a bronchus, all right? And until we get down to those really tiny ones of just 1 millimeter diameter, where we no longer have to worry about it collapsing on itself, the smooth muscle has enough body to keep it open, all right? Those are the bronchioli, all right? Those are the bronchioli. And the bronchioli will take us the rest of the way, finishing out the conducting portion of the airway. Okay. When we talk about asthma, there used to be, you guys weren't even born probably, there was a baseball player named Bob Gibson, and he was famous for, he was a pitcher. He was famous for his advertisements for some bronchial asthma product. All right. You know, it's always here's the baseball guy and doing his bronchial asthma thing, and it always bugged me, right? Because asthma, while it does include the bronchi, it's mostly the bronchioli. And Bob Gibson should have been talking about bronchiolar asthma, all right? Because that's where the real diameter change makes a big difference. When people are having a really hard time breathing, who's been around an asthmatic or maybe suffers from that condition from time to time? All right, yeah. It's at the level of the bronchioles. You close those off, they're only 1 millimeter in diameter. How's that air going to flow for you? Yeah, you can imagine how serious it can be. Closing down the bronchi, yeah, it's going to limit your ability to move air, but you close down the bronchioli, you're shutting down the system, right? And people die, right? Sure. Okay, so that takes us to the end of the conducting portion. And here again, you see these bronchopulmonary segments. All right. I'll say one other thing that's pretty interesting, and that is there's something called ventilation perfusion balancing, which is pretty neat. All right. It's a pretty neat phenomenon. And you may or may not hear about it in your physiology class. I don't think Mr. Fuller talks about it, but you'll get it sometime down the road. And that is that here you're sitting down, all right, and that big Chipotle burger that you ate is pushing up against your diaphragm, and it's preventing inflation of that lower part of your lungs because there's all kinds of pressure on it. So as you're breathing, you're more inflating one part of the lung versus the other part. Okay? So what do you want to do in terms of blood supply to the different parts of the lung? You want to correlate blood supply with those regions that are being ventilated, either high blood supply to the well-ventilated areas, and lower the blood supply to those areas that are being more poorly ventilated, because you're not going to be exchanging that much gases there anyway. There's no reason to run a lot of blood through those tissues, right? So we call this ventilation, perfusion, balancing, all right? And it's balancing between the amount of air that's going there and how much blood. So it's vasodilation or vasoconstriction, opening up or closing those blood vessels to match the amount of air. And that's happening at the level of the bronchopulmonary segment, all right? It's called ventilation, perfusion, balancing, and that's happening at the level of the bronchopulmonary segments. All right? So those bronchopulmonary segments have several important indications, right? When we think about infection, when we try to understand simply the architecture of the lung, when we think about things like controlling ventilation, perfusion, balancing, right? And here you see them depicted here in their various colors. Let's see. Should I have you memorize all of the bronchopulmonary segments? No. Okay. Never mind. I'm just kidding. All right. So at last, we're talking about the respiratory system. It's about time we get to the part where gas exchange happens. All right. So we've gotten down now to the respiratory portion, and the respiratory portion includes respiratory bronchioli. Well, that doesn't make any sense. Well, what we're saying is that when we get to the end of when we get to the terminal bronchioles, all right, that's a terminal bronchiole, and I know it's a terminal one because the very next thing is a respiratory bronchiole, all right? And the difference is that in the respiratory bronchiole, there's going to be the occasional little alveolar sac. All right? And so I know that gases are able to be exchanged along this passageway. It doesn't look that much different from this. It's got smooth muscle in it, all right? But it has the little alveoli. And therefore, there's going to be gas exchange there, all right? And so that's a respiratory bronchiole, all right? When we get beyond that, we get down into alveolar ducts, where now we're going to have a duct that is made up of a passageway of alveoli, and then eventually we're going to get down into an alveolar sac, all right, the dead end, all right, of our respiratory system, okay? And as it's described in your book, and you see it on the figure here, these little alveolar sacs, or alveoli rather, are 1/4 to 1/2 millimeter in diameter. You've got 300 or 400 million of these, all right? And this is the functional unit of the lung. This is where the action is. This is where gas exchange is going to take place, where blood vessels, I should say the pulmonary capillaries, right, form a network over the surface of these tissues, all right, to allow for gas exchange to occur, all right? Now, because you have a bunch of these alveolar sacs, all right, butting up against one another, all right, something like that, okay, you find that there's pores in between them. And those pores simply neutralize the pressure differences between these. All right? So when you think about that air going down into that bronchopulmonary segment, all right, you want all alveoli to get the same basic pressure. And so you have little penetrations between these little pores, all right, to neutralize any pressure differences between these, to balance the air pressure between the different alveoli. All right? And again, as we've said, and as you see in this figure here then, the pulmonary artery comes into the lung. It subdivides into many, many tiny capillaries that form a network over the surface of the alveolar sacs, all right, and eventually those converge into pulmonary veins. You had a question earlier. Okay. Yes, Edie? It's got to extend over anything that's going to be involved in gas exchange. All right? So any place that you see it, whether it's a respiratory bronchiole, whether it's an alveolar duct, whether it's at the end of the alveolar sacs, all of those are going to be covered with capillaries. Anywhere there's an alveolus, anywhere that we're talking about gas exchange, you're going to have capillaries covering that surface. All right? When we talk about then gas exchange, all right, we're talking about a process of diffusion, right? And diffusion is only good over short distances, right? We've talked about this before when we looked at the epithelia, and we said if the epithelium is involved in some diffusion process, it better be what kind of epithelium? Simple, squamous, all right, thin, flat cells. And so when we look at the alveolar wall, all right, so we're zooming in here, guys, all right, so we're down here, we've zoomed in, these are individual alveoli, right? And when we look at the wall between these, of course, there's going to be blood capillaries there, pulmonary capillaries, and we want oxygen to diffuse from this space into that blood plasma. All right, and once it gets into the blood plasma, it can diffuse into the red blood cells and be bound by hemoglobin. All right, we won't worry about that part of it. What we want to know is how does it get across from the alveolar space into the pulmonary capillaries. All right. Well, what are the barriers there? The first is the cells that form the pulmonary epithelium, the lining of the alveoli. All right, and these are called type 1 pulmonary epithelial cells, all right, or alveolar type 1 cells, all right, and they are the simple squamous epithelium that covers the vast majority of the surface of the lung. This is where gas exchange occurs. They're squamous cells, all right. What's the other cell that the oxygen has to pass through? The capillary wall, the endothelial cell wall. All right. So you've got the two surfaces of membrane of the alveolar type 1 cells, right? In other words, if we were to cut an alveolar sac in, let's put a capillary. Well, we've got our capillaries here. So if this is the wall of the alveolus, all right, the oxygen has to pass across the cell, meaning it's passing through two cell membranes and a very thin squamous cell, right? And here's a blood capillary here, right? Again, the blood capillary is forming. There's our red blood cell. Okay, so we've got to get through both surfaces of the cell, the one facing the alveolus and the one facing, what's this in here, you guys? What's that? That's the basement membrane, right? This is an epithelium. Epithelia sit on basement membranes, yes? All right, there you go. So there's the basement membrane. So what we have is this distance here, all right, which is the respiratory barrier, if you will. That's the distance that gases have to pass across. It includes passing through the alveolar type 1 cell, passing through the fused basement membrane of these two cell types, and passing through the endothelial cell forming the capillary. All right? And that is the respiratory barrier. All right? I'll add to that the fact that that there has to be oxygen. There has to be water, a layer of water here. All right? As I mentioned to you last time. And the reason is because before gases can diffuse, they must first dissolve into water. diffusion occurs through a liquid medium. All right? And so before these gases, before oxygen can actually begin to move across the cell, it must first dissolve into this layer of water. All right? And once it dissolves into that layer of water, then it's free to diffuse through the cell, through the type 1 alveolar cell, through the basement membranes, which you know are freely permeable, and through the endothelial cell into the blood plasma. All right, in the blood plasma. All right, now, in addition to these alveolar type 1 cells, all right, that form the squamous, simple squamous epithelium, there's another cell that you see scattered about here, all right, known either as alveolar type 2 cells or as septal cells, all right? And these cells function to produce pulmonary surfactant, all right? And pulmonary surfactant is a mixture of lipid and protein. It's a phospholipoprotein, all right? And it mixes with this water layer, all right? And let me see if I can explain this and keep it pretty simple, and we'll come back to it later, all right? If this is an alveolar sac that I'm drawing here, all right, and this is the layer of water found within that alveolar sac, okay, there's some water in there. Water, as you know, when it's in contact with lipid, which is the cell membrane lipid, right? When water is in contact, what does water want to do? It wants to bead up, right? The surface tension that's intrinsic as one of the properties of water, all right, wants that water to bead up. And so, in essence, that water, as it beads up, wants to collapse the alveolus, all right? Now, when you go to inflate the lung, all right, you're going to turn that lung into, or that alveolar sac into something bigger than what it was in its deflated posture, right? And what does that mean? You have to spread that layer of water out. But that water doesn't want to spread out. That water wants to bead up. It wants to go the other way. Does that make sense? Okay? So, how can you reduce the surface tension forces of water? You mix it with pulmonary surfactant, all right? And the pulmonary surfactant works like a detergent, and I should have said that earlier to you, all right? It works like a detergent. Do I need to make that a little bit more clear? Do you get it? If you go to a lake that's really clean, it's absolutely pristine, all right, for a picnic, you're going to see those water walkers skidding around on the surface of the water. Jesus bugs, they're sometimes called, all right? All right? And if they're skittering around on the surface of that pond, you know that water is clean, all right? Because the surface tension forces between the water are nice and strong, all right? But if you don't see any water walkers, it's because there's detergent in the water. And the surface tension forces between the water molecules are interfering with the attractive forces of the water to other water molecules. And when that Jesus bug steps out onto the water, guess what he does? He goes straight down. All right? So that's what you're doing here. You're adding a detergent, pulmonary surfactant, to lower the surface tension forces with the water. And what is that going to mean when you go to inflate the lung? It's going to take less energy. Okay? It's going to take less energy, and that's important when you're an infant especially, because if you don't have surfactant because you've been born prematurely, you can die of respiratory distress syndrome because you get tired of having to expand the alveoli and work against the surface tension forces of water. All right? And one of the things that determines whether a prematurely born infant can survive is the amount of pulmonary surfactant. I'll say a little bit more about that next time. There's things you can do to ameliorate that. That's right. That's right. One of the things that they can do is to give the mother a cortisone shot, which seems to stimulate the production of surfactant in that developing fetus. All right. So I was hoping to get a whole lot further than that, but at least we've made something out of this. So